Hello and welcome to this episode number 4 of our monthly CMF podcast. My name is Tina Vilsbøll. I'm a professor at the University of Copenhagen in Denmark, and I'm a consultant at Steno Diabetes Center, also in Copenhagen, Denmark. Today, I'm joined by Naveed Sattar. He is a professor and honorary consultant at the Institute of Cardiovascular and Medical Science in Glasgow. Welcome. Nice to see you, Naveed.
Hi, Tina. Yeah, nice to see you too. So the CMF, which really stands for Cardiometabolic Forum, is a free educational resource for clinicians. And this podcast aims to keep you up to date with the latest information and data in the field of cardiometabolic diseases. So in this episode, Tina and I will go through a couple of interesting papers published in January 2022. So the first paper we want to discuss is actually, you can see now, it's the effects of canagliflozin and metformin on surrogate markers of insulin resistance and visceral adipose tissue in people with newly diagnosed type 2 diabetes. And this was an open-labeled, relatively modest single-center study, which compared canagliflozin versus metformin over 3 months and its effects on HOMA-IR, which effectively uses fasting insulin glucose to work out a surrogate measure of insulin resistance, and also looked at visceral adipose tissue. And as you can see in the results, the evidence that suggests that canagliflozin was better at reducing both HOMA-IR and linked to this probably visceral adipose tissue. It also had a better effect on lowering CRP, and other factors that they found in this particular open label study is that there was an association between improvements in visceral adipose tissue and insulin resistance, as well as nitric oxide and HOMA-IR, I believe. So, Tina, relatively small study, short duration, 12 weeks. What's your take on this? Anything surprising to you?
Well, not really. I am a big fan of metformin, and I'm also taking the SGLT2s into my clinic. I think it's a nice, I would say, small study. It has a limitation of indeed being open label. It's a single center study. It's only in Chinese people. It's only 12 weeks, but I mean, it has attention towards the visceral fat, and we are moving more and more into when we treat our patients to convince them that it's not only about the body weight, visceral fat, inflammation, and all that is also important. I think it's fine, it's great, and not really surprisingly. We have data from the phase 3 trials with pretty much all the SGLT2s also looking into body composition, but it's interesting in a small population.
Yeah, and the things that I think slightly surprised me in this study, I couldn't work out whether it was how well it was randomized, but they didn't really see much of an effect of metformin. So I wondered whether they were on baseline therapy of some kind. But nevertheless, because you would expect a better benefit of metformin as well, wouldn't you, Tina?
Yeah, I am a big fan. I've been accused for being in love with metformin. I really enjoy using metformin. It has moved in patients with cardiovascular disease and chronic kidney disease. You know, if I should choose between SGLT2 or GLP-1 first, I go for them first, but I really like to have metformin in my toolbox. Us who see patients, we still love metformin, I think.
Yeah, and of course, metformin is, you know, it's cheap. It's been used for many years, and it's available to nearly all parts of the world. So it's still a very important therapy for many of our patients across the world. I guess the other thing I was a bit, you know, when we talk about CRP as a marker of systemic inflammation, yes, it is. But what we don't really know is to what extent that inflammation pathway is causally related to some of the things we see. We guess that they are, but we're not fully sure. Would that be fair, Tina?
Yeah, that's right. We still have, there are many more things which it could have been measured in this trial. But yeah, I mean, great trial, interesting data, not groundbreaking, I would say.
Yeah, okay. Well, that then leads us on to the second paper, which, Tina, I think probably you're in a very good place to cover. So if we go over to the second study.
Yeah, that's a more, you could say, regular, straightforward, large, very high quality trial, I would say. It is the step 6 trial. It's semaglutide once weekly in adults with overweight or obesity, with or without diabetes. Only 25% of the patients actually had diabetes, so it was not what brought them into the trial. But it's semaglutide in an East Asian population, and the classical randomized double-blind, double-dummy placebo-controlled phase 3A trial. It is not as we know it from diabetes doses of sema, but it's 2.4 milligram once weekly, which was evaluated then in this group, 440 patients or so for 68 weeks in the trial. And as what I've ever seen in Asian people, more efficacious than what we know. I think we all know from the full STEP program that 2.4 milligram of semaglutide is efficacious. But here, as you can see to the results here, a 13.4% body weight decrease in the patients treated with 2.4 milligram. There was also an arm with 1.7 milligram of semaglutide, but very, very pronounced effect. Actually, it was so that patients came from around 90 kilos, and 2 out of 5, so 20% of the patients actually lost more than 20%, giving like 1 out of 5 losing more than 18 kilo. That's very pronounced effects. What they also looked into in this trial was visceral fat. They did CT scans of these individuals, and with sema 2.4 milligram, they actually saw a 40% reduction in visceral fat. And I am a big fan, you know, Naveed, that I'm a big fan of GLP-1. I also enjoy SGLT2s. But when I sit in front of my patients, our dietitian, they really do bioimpedance, looking into the visceral fat. And it is really an eye-opener for many of our patients that with these modern glucose-lowering drugs, you lose the unhealthy visceral fat, which was very, very pronounced in this trial. What they also looked into, of course, is that the side effects of GLP-1s are dose-dependent. So yes, more patients had side effects with the higher dose of sema, and of course compared to placebo. But in real life, in clinical life, patients, they do actually not bother. You can decrease them, you can go slower in real life. That's what's usually done in the trials. But in general, side effects were, as we know it from the class, dose-dependent, transient, and driven by gastrointestinal side effects. What I loved here is, again, that actually no cases of pancreatitis, which is indeed interesting. I don't know if you agree with me on this one, Naveed. What do you think?
Yeah, no, I think it's an important study in many respects, because obviously all the prior STEP trials were predominantly in sort of white populations, high-income countries. So, and of course, you know, you and I know that there are rapid rises in diabetes in Asian countries, including Japan and South Korea. So to see the effect of semaglutide in terms of glycemia and particularly weight and also visceral fat was important. I guess back to you, Tina, I'm getting, I was involved in the DIRECT study, weight loss, and as you lose weight, you improve liver fat and visceral fat. And to my sense is, if you have treatments that lower weight more, that is an upstream improvement in the pathways that lead to hypoglycemia. So you might also anticipate better glycemic benefits with this newer class of drugs. Would you agree with that, Tina?
Oh yeah, very much indeed. Because we say right now, well, you have diabetes if you have above 6.5 or 48 millimoles per mole, as we use here in Denmark and many countries in Europe. But it's a continuum, and obese individuals with loads of visceral fat, we know that they're insulin resistant, and it's the life story of metabolic syndrome, whatever you call it, and diabetes. So yes, that's indeed very important also.
Yeah.
And that's what we use in the clinic, isn't it? I mean, we are beyond glycemic control only because and that's one of the things we discuss a lot. GLP-1 is expensive, so is SGLT2s. But what I really can see from my clinic is that maybe cholesterol is slightly increased, blood pressure is on the level. So should I add another antihypertensive agent? Then I start GLP-1 or SGLT2, and then you actually save a blood pressure lowering agent. Or it's not that it should go instead of, and you should still give loads of statins, but it's a matter of should you push the atorvastatin up to 80 milligrams or add another statin or a cholesterol lowering agent, and that's something that we need to take into consideration when we sit in front of the patients, that with these modern classes, we get more than just effect on glucose, and we even save lives with these classes as well.
No, you're completely correct. And it's a very salient point that you made. I mean, we're at this point now, we have so many therapies we can throw at our patients, but I guess at least we have new tools that can work partly upstream by not all, so that they're targeting mechanisms of outcome harm. And I think drugs that do lower weight more substantially, certainly once they become more affordable in the future, Tina, I think we'll be using them early in the course of type 2 diabetes, unless we get much better at lifestyle-induced weight loss, which may happen, but we've still got a long way to go there. So I think this is really important to see, particularly in a population susceptible to type 2 diabetes. So I think it bodes well for the future. But you would agree with that, Tina?
Yeah, I certainly do. And right now, I mean, we don't have CMF for obesity in Denmark and in Europe. We'll have it soon. And I think right now, if you just are at the level of having diabetes, I mean, HbA1c of 6.6, you have loads of potential treatments.
Yeah.
It's often, refunded by or paid by the government. You have clinics. You can really have high-level evidence-based therapy. But if you're just below the HbA1c in respect to not fulfilling the criteria of having diabetes, you can be morbidly obese, hypertension, dyslipidemic. We actually do not have good enough offers for these individuals. And with the science piling up, STEP trial here, tirzepatide, dual agonist in the future, triple agonist, we really have a new area for the treatment of obesity and diabetes.
No, I think you're right. And I think there's quite a lot to be optimistic about. Of course, affordability is going to be the big question in many countries, but listen, at least we have the tools. And over the next few years, we'll have probably much more evidence about these drugs, particularly about outcome benefits as well. So I think it's exciting, and it's lovely to see this study. So yeah, thank you.
Yeah, and we might save some money even. I mean, they get less cancer, liver diseases, and all that. So.
Well, okay. No, I think actually that last point, Tina, is very important. I think it allowing us to treat upstream, rather than just treating the very small downstream benefit, outcome benefits, and treating upstream, as you just nicely said, can actually prevent many other conditions, comorbidities in diabetes, which are very common. Yeah.
Okay, thank you very much for meeting today, Naveed. It was an honor to join you, and I hope all of you out there will have a good day. Thank you.
Yeah, and to everyone else, to view these publications uploaded this month, you can access the other resources. So head over to the CMF at cardiometabolic.com. You can also join our mailing list and follow us on social media so that we can stay in touch with you and let you know the moment an update goes live. Thank you very much, and thank you, Tina.
Thank you.